Welcome to the Affirming Minds podcast, where we equip like-minded mental health professionals with a therapeutic toolkit that helps add to a more engaging, fulfilled, and effective mental health practice. Each empowering episode can stand alone as a continuing education pod course or a very valuable professional or personal resource with insightful expert interviews, practical resources, industry news, and lots of inspiration. We help the modern therapist thrive at work. Now let's welcome your host, a dedicated therapist and passionate educator, Shauna Cyber, LCSW.
Welcome to the Affirming Minds podcast. I'm your host, Shauna Cyber. I'm so happy that you tuned in today. This show is for educational purposes only and is not a substitute for professional treatment or clinical supervision. If you're in need of support, please reach out to a licensed mental health professional in your area. Whole clinical examples shared are fully de-identified, composites, or vignettes. No real client information is ever disclosed. If you're interested in earning continuing education credits for this episode, head to affirmmentalhealth.com. Our membership gives you access to CEs for live virtual workshops, self-study webinars, and eligible podcast episodes right here on the Affirming Minds podcast. Today, we're going to be talking about ADHD in high-achieving BIPOC clients, how it often goes undiagnosed, how it intersects with perfectionism and imposter syndrome, and what clinicians can do to offer culturally responsive and affirming care. I'm honored to be joined by Dr. Shauna Pollard, affectionately known as Dr. P, a licensed psychologist and nationally recognized expert in executive functioning, ADHD, and culturally responsive therapy. Her clinical work lives at the powerful intersections of high performance, executive dysfunction, and identity-informed care. She works with high-achieving professionals, particularly in tech, healthcare, and academia, many of whom are incredibly successful, but are privately navigating chronic overwhelm, self-doubt, and cycles of perfectionism and burnout. Through her private practice, Dr. P serves clients across multiple states and is authorized to practice in over 40 states via Site Pact. Her approach blends evidence-based interventions with cultural humility, helping BIPOC professionals break internalized patterns and pursue success with greater ease and authenticity. She also facilitates a virtual support group for BIPOC clinicians with ADHD and offers therapy intensives, deep focus sessions designed for lasting change. Dr. P regularly presents to businesses and organizations on neurodivergence in the workplace, procrastination, perfectionism, and how to create spaces that support sustainable achievement. Before earning her doctorate, she spent 6 years conducting research aimed at increasing minority representation in STEM fields, a mission she continues through her clinical and consulting work. She earned her PhD in clinical psychology from the University of Maryland, Baltimore County, and her BA from Emory University. She completed her internship and postdoctoral fellowship at the Memphis VA Medical Center, where she trained in evidence-based treatments for both physical and emotional well-being, including trauma, depression, and behavioral health integration. Before we dive in, I want to offer a quick primer on some of the terms and frameworks we'll be using in this episode. BIPOC stands for Black, Indigenous, and People of Color, a term used to highlight the distinct and intersecting experiences of systemic oppression, marginalization, and cultural identity that often shapes access to care, diagnostic disparities, and lived experiences in both clinical and non-clinical settings for these communities. ADHD, or attention deficit hyperactivity disorder, is a neurodevelopmental condition that presents in 3 forms: inattentive type, hyperactive and impulsive type, or combined. According to the DSM-5, it involves a persistent pattern of symptoms lasting at least 6 months that interfere with functioning in 2 or more settings. This can include 2 or more settings like school, work, or interpersonal relationships. Inattentive symptoms include distractibility, forgetfulness, poor follow-through, disorganization, and difficulty sustaining attention. Hyperactivity or impulsivity symptoms include restlessness, fidgeting, excessive talking, interrupting, and difficulty waiting one's turn. These symptoms must begin before age 12 and significantly impair functioning. But for many women and BIPOC individuals, ADHD is missed, masked, or misdiagnosed, leading to years of internalized shame and burnout. Executive dysfunction refers to difficulties with self management processes like planning, initiating, completing tasks, time management, emotional regulation, and mental flexibility. These are core deficits in ADHD, but are often mistaken for laziness, irresponsibility, or lack of motivation, especially in high performing individuals who learn to mask their struggles to meet societal or cultural expectations. In today's conversation, Dr. P explains how perfectionism and imposter syndrome often develop as survival strategies for neurodivergent BIPOC clients, especially when they're navigating environments not built with them in mind. We also discuss the diagnostic blind spots in adult ADHD assessment, the emotional toll of masking, and how clinicians can apply culturally attuned evidence based strategies that affirm identity, protect dignity, and foster real sustainable change. This is one of those episodes that will expand how you think about both ADHD and cultural responsiveness, and I'm so excited to share it with you. So let's get into it. Dr. Pollard, thank you so much for being here today on the Affirming Minds podcast. I am so excited to get into it today. Can you start by introducing yourself to our audience and sharing what brought you to focus on ADHD?
Yeah. Hi, I'm Dr. Shauna Pollard. I'm a licensed psychologist. I'm licensed in Maryland and Georgia, and I have the site pack, so I see folks in all of or I'm allowed to see folks in all of those states. And I specialize in working with professionals with ADHD, folks who work high intensity jobs and have done very well in a lot of ways, but hit a snag and need some support. And how I got interested in doing the work was more the clients started coming to me. I started my graduate career actually doing research on high performers in STEM and so how to support underrepresented minorities into getting into STEM, science, technology, engineering, and math, STEM fields at the doctorate level. So I did this work while I was working on my PhD, and I think it started to set the frame for me about the literature on best practices for supporting students of color and particularly Black students, and really getting to know that population well helped out a lot once I moved into more clinical work. And I would see folks who had been peak performers at some point in their careers, but had hit a snag and kind of needed support in getting past that. And so the more that I did clinical work, the more I would run into people with ADHD diagnoses. And I did my internship and postdoctoral training at the Department of Veteran Affairs in Memphis. And so I had training in evidence-based practices for trauma, PTSD, depression, that sort of thing. So I felt pretty confident in that area. But all I knew about ADHD was what I used to help myself get through graduate school. So I was a late diagnosis, wasn't diagnosed until probably the end of my graduate career. I was working on my dissertation. And so I had started listening to podcasts and learned a lot about executive functioning tools. And I would use those same skills with clients. And so once I started getting a lot more clients, then I started doing more official trainings on how to support folks with ADHD, how to support autistic clients, because those were the folks that were coming into my office. And those also the folks who had experienced lots of trouble working with other providers and felt like their needs weren't getting met adequately. So that sort of motivated me to do more training in that area. So that's a long response, but that's
No, and so helpful. And I really appreciate both how your educational journey took you in this direction, but also your lived experience. I do hear that from so many people that I work with as well, that late in life diagnosis around ADHD. And I do see this prevalence of a lot of women with later in life diagnosis, a lot of BIPOC individuals with later diagnoses. And I just really love that a lot of where your expertise lies is naming explicitly both these intersections of like neurodivergence and ADHD generally, but also how we're seeing these in these like high achieving populations. And then also how there might have been a lot of cultural bias that added to a lot of people being missed and not given the appropriate supports earlier in life. I think that's absolutely fantastic that you really honed in on that specialization. From your clinical standpoint, how do you see ADHD and perfectionism, high achievement commonly interacting? How do these two things wind up relating to each other?
Yeah, I think the top of mind way I see it most is that perfectionism can be a compensatory strategy. So if you think about it, folks with ADHD might feel like they're always getting things wrong, they're always making mistakes, they can't do things correctly. And so some folks find that like they manage that by becoming more perfectionistic and trying to hide errors or mistakes by putting in extra hours, by checking every email, reading emails multiple times, being really strategic in how people respond, staying late. And so I think the principal way that I think about it is that it can be a way that people try to manage having ADHD and try to, without knowing it, how they're masking.
Yeah, and I think that's really interesting to seeing an compensation behavior because I can absolutely relate to that. I can see overwork becoming a coping mechanism, this creative survival strategy to keep it under wraps.
And I think it's particularly relevant or salient when folks have that triad of ADHD, anxiety, and then the perfectionism comes about. Because I think you have to have a certain level of anxiety to compensate in that way.
Yeah.
Obviously, everyone with ADHD does not have perfectionism.
Yeah, no, absolutely. How do you see imposter syndrome showing up in neurodivergent clients? And why do you think this is something that's often missed in ADHD treatment planning for this population?
Yeah, maybe I'll start with the last question first. I think, first of all, there's nothing about imposter syndrome in the DSM diagnosis of ADHD or even anxiety. I think it's something that people don't think about when they're doing assessments. And I think the way that it shows up is principally at an emotional level. So it shows up as guilt, it shows up as shame, it shows up as low self esteem. And so when it does show up in my office, I will often push back on people in terms of, is this a personal issue? Or are you actually getting feedback from the environment that the way that you do things is not considered okay or that you don't belong there? Because sometimes I think imposter syndrome can be framed as, oh, this is a personal challenge that you have to work through. But if people are saying to you, like, you're doing it wrong, or if they're giving you verbal or nonverbal cues that you don't belong in the environment or people like you don't fit or you shouldn't have access or you're not deserving of access to accommodations, then I don't know if it's fair to it may feel like imposter syndrome, but I think we have a slightly different issue if you're getting feedback from the environment that like you don't belong here.
Yeah. Yeah. So it sounds like really doing that discerning and not like pathologizing something that might be more systemic, might be more interpersonally experienced.
Yeah, and I think that's something that was a big part of my training. One of the emphasis that was a part of my graduate program was community psych. So I think I always come in with the lens of not just looking at the individual level, but it's a full Bronfenbrenner model of what are all of the systems and all of the influences at various levels that are influencing individual functioning. And so anytime I'm not good enough and then also probably because I'm grounded in CBT. So I often will challenge that cognition of, is it true that you're not capable? Or do you maybe just feel capable if you're in a state of burnout or because you experience so many failures? So I think it's really important to push back or to be curious when you see the imposter syndrome come up.
Yeah, absolutely. So, what are some misconceptions that you think therapists may have about how ADHD presents in BIPOC clients?
Yeah, I would say maybe people might have the perception that ADHD is not as common in communities of color, and I don't think that's true. When you look at the research, there's studies that shows in some places that it is more common, is more frequent, which I think goes against what it says in the DSM. And so I think a lot of times what I hear anecdotally from clients and folks that I know who have explored ADHD diagnoses are that the providers are often like, "No, I don't think that's what's happening." And I think sometimes it comes from a lack of knowledge about ADHD, because if you think about it, if you're an adult person, or at least let me speak for myself, when I was trained in my graduate program, there was no training on ADHD for adults. And so if you think about it, like, it makes sense that people might not know what it looks like in communities of color or might not be thinking to look for it. I think when you're dealing with communities of color, what you might be seeing is some double masking going on. And so you might see that there are some folks who are hiding the neurodivergence, like we talked about with that perfectionism as a compensatory strategy. So they might be performing well, and so you may not see, or they might not articulate that they're having problems because they do so much to try to compensate and to try to manage. And then also, if folks don't feel comfortable being authentic in environments where there's a difference in ethnic and racial background, then they might not be bringing their full selves to the therapy space. So I don't know if I would say it's a misconception so much as that people might not be able to see it, because if you're not super familiar with what the cultural norms are from that background, you might not notice certain things, or the person might not feel really comfortable talking about their problems. That's one thing I think I see sometimes in communities of color, that is there's a tendency to present that things are better than they actually are, especially in the beginning of a relationship, especially when folks are unfamiliar with the provider. And so it may be a while before the person feels safe enough with you to really talk about some of the things that bring them a lot of shame or guilt.
Yeah, absolutely. And I think the piece of also it not being visible, it had some really fantastic guest speakers come up and talk about bias in eating disorder diagnosis and treatment. And I think for we as therapists, if a lot of our conditioning in not just our training, but in media representations and things like that are okay, that people with eating disorders are generally white, cisgender women. That when we are in a community that doesn't reflect that, it's just we might have this bias that is it's just not registering us to do a full assessment or just deeply look at this or keep that top of mind. And like you mentioned, I very much relate to that, not getting ADHD training specifically for adults. So then when you're doing adult assessments, it's just not as top as mind as when you're doing the pediatric evaluations. And then I think coupling that with some of the biases that happen. I worked primarily in the Bronx for the last 15 years or so in my early career. And there was a lot of a very like racially diverse community. And we saw all sorts of kids, but I could even see anecdotally the way that we would get reports from teachers might the same symptom cluster potentially might be language difference, frame difference for a white passing child and a Black child. And the communication and like how things are being framed all can lead to that. And I think anecdotally, I think something I saw was things like oppositional defiant disorder being over-diagnosed in pediatric populations that were primarily Black and Hispanic, and potentially ADHD being overdiagnosed in populations that were primarily male and white passing. So I think those are like the things we really have to always like be checking in with ourselves of especially when we haven't had a lot of trainings for a specific population or with a culturally responsive lens. So I really appreciate that piece being brought up.
I love what you said about that. I think that absolutely tracks with what folks have said. So I have a unique experience, perhaps, in that I haven't worked with children in that capacity, and so I think that's what the literature have said, that people will get funneled. That clients of color will get funneled into other diagnoses, that maybe an ADHD diagnosis and adequate treatment could have prevented those things, or they may be misdiagnoses completely. I think that also can make it harder for adults, because part of the criteria is that you had to be showing symptoms from a certain age. And so if there are biases in assessment at the child level, what that means is there will be a lot more people who don't have that history. And then they also won't have the collateral data to back up a diagnosis in maybe the same way that a comparable peer who's not a peer of color would. And so I think all of those things make it challenging for
Yeah,
sure.
absolutely. Absolutely. And I think that it's a very concerning thing with ADHD, particularly because I think when those are missed, what I think oftentimes like the executive functioning pieces are missed and they are looked at as more of a personal failure. They're often looked at as lack of effort. And I think there's could be nothing more, heartbreaking for a child that is really struggling for something that they just need more support and accommodation, and they're being told they're not trying hard enough. and like what is the frustration and of course like the behavioral responses that are ultimately going to be coming out if you are not getting adequate support and being told you're just not trying hard enough when you are putting so much effort in. So I think it is something that I could understand just compounding over time.
Yeah, and I think it speaks to the fact that I'm aware that I only deal with a very small segment of the population. But if folks have had those experiences that you described, they may not complete their education. They may end up interacting with the justice system a little bit earlier. They may have their lives impacted in ways that don't allow them to recover as easily as someone who ends up still being able to be good academically. And so I think all of those things you mentioned are really spot on.
What do you think are some of the internalized cultural messages, maybe around success, about respectability, about survival, that impact the development of perfectionism or some of the things that we've been talking about in BIPOC clients?
Yeah, so I think what you said actually directly correlates that if the executive function piece has been missed, then there might be these internalizations about I'm lazy. I
Mhm.
should be trying harder. I should be doing better. You have the general societal norms around laziness, but then I think there may be a different flavor that takes for certain ethnic groups. I'm absolutely seeing where folks have internalized I'm lazy or I'm not trying hard when in reality, like you said, they're putting in a lot of effort, but the effort is not yielding the results that they are trying to get or that they're being expected to produce. And instead of being given support and accommodation, they just internalize that and have more guilt, shame, avoidance, and procrastination. And then they characterize that as laziness. I think certainly within the Black community, there's the strong Black woman stereotype where you might see some of that as well, of like folks being expected to carry a lot, to do a lot. And so if you have executive functions, that means it's harder. That means that it's harder for you to do a lot. Then there's going to be that shame around that. It's just this idea of over functioning that shows up. And I think that's regardless of background, really, that late diagnosed ADHD folks who work these high intensity jobs or jobs that demand perfection or over functioning, you might get someone who falls into that cycle of doing too much and doesn't know when to dial it back. What is normal? What is reasonable? Because they've never been able to put forth a normal level of effort and achieve what everyone else has achieved. They've always had to put in twice as much. So even once they are caught up, sometimes then there becomes this idea of what is enough. And if you come from a background where maybe your family immigrated to come to this country, there might be the sense of I'm not working that hard compared to what my family of origin had to deal with. And so yeah, it can be a lot.
Yeah. And I think that's a really important point that you're making about the particular cultural context of anybody, if somebody is first generation or has an immigrant experience themselves, those really internalized messages about what the sacrifice that was made for you and then what that means about what your work ethic and your output and what you were supposed to do to leverage this opportunity that you now have. So I think that piece about our value being intrinsically tied to our output comes from so many spaces and our capitalistic culture in general. But then when you really get into the nitty gritty of like how these like really specific cultural frameworks can then just amplify that so much more, it's really interesting.
Yeah, and people are socially rewarded for perfectionism and financially rewarded. And it's good until it's not good anymore. So I think that makes it hard because there's a lot of external encouragement. And then I think the other piece that may be more salient in BIPOC communities is that failure doesn't feel just personal. It feels like you didn't just fail for yourself, you failed for everyone else that looks like you, everyone else that has the same background. And it's like you were supposed to be the one who makes it. So if you're making mistakes, if you're getting things wrong, if you're getting fired, then it's not just a personal failure, it's a global failure. And that can be a really tough hit to the self-esteem.
Yeah, just like such an intense pressure. Really, like can completely, yeah, see that where you're you feel like there's this almost like cultural representation that you're doing that's being thrust upon you. And so it goes beyond this sort of individualist framework that we're sometimes in mental health, like thinking, like, and applying people to. But if people have a lot more collective values, then where they're actually feeling like, no, this is my success is also for my community. That's an incredible weight to be carried.
Yeah. And I think it should help us really think about when we're trying to remove people's perfectionistic behaviors or discourage that you really want to be careful about that because it's layered, it's
Yeah.
complex.
Yeah, absolutely. I think it is such a nuanced question of wanting to encourage people in their pursuit of excellence and not g- mirror harmful messages of low expectation that people may be getting, all doing that in a way that feels like empowering and not like in this really fragile system where you can't be fallible, you can't be vulnerable, you have to be amazing in everything. It has to happen at a certain pace in a certain way at a certain time. So I can definitely see that being a delicate to balance. Something I've also seen with some of my late in life diagnosed folks with ADHD, because beyond focus and that some of the things that I think have been deeply internalized in terms of messaging is about like cleanliness and organization. If they struggled with maintaining a clean environment, keeping their space organized, I think a lot of people internalize messages that they're dirty, that they're incapable of managing themselves in that way. And that can create a lot of hopelessness. And I've seen in both ways. Sometimes it created like almost compulsive behaviors around cleaning and perfectionism, or people are like, I can't do this. And there's avoidance and procrastination where managing day to day like activities of daily living, like around maintaining their homes and laundry and like even sometimes personal hygiene become really difficult because it was so personalized rather than looking at the context of maybe there was something, an executive functioning issue going on. And I think another thing I've seen people internalize, which is really incredibly creative, intelligent, smart people that I work with internalize messages that they were dumb because they would be forgetful. They'd forget things here and there, or these executive functioning issues would make them not great at standardized tests and things like that. And those messages were really internalized as well. And I think that is, again, one of those things that can be really heartbreaking to see. And that sometimes I'd have mixed feelings about the DSM-5's utility. We also know like the challenges inherently, but I think for some people getting this late in life diagnosis can be so validating because it takes away some of that shame. It's not just I'm bad and dirty and stupid and all of these other things and not enough and not trying hard enough and lazy. So I think that's incredibly important. And now a quick word about our amazing sponsor, Jane.
Can we agree on something? Therapists are already doing enough. You're managing care, notes, scheduling, billing, all while holding space for everyone else. The last thing you need is a system that makes it harder. That's why I switched to Jane. It's intuitive, it's beautifully designed, and it just works. It saves me time and protects my energy. The customer support alone is worth it, but the smoother workflow, that's what made it a long-term solution for me. Use code AFFIRM1MO to get a 1-month grace period. Switch to Jane and see what it feels like to be supported by your EHR for once. Time to decide if Jane's a better fit.
Big thanks to Jane for supporting this podcast. And now back to the interview. What do you see as some of the structural or systemic reasons ADHD is underdiagnosed or misdiagnosed in BIPOC communities?
Yeah, I think first of all, ADHD is just hard to diagnose. If you think about it, it's mainly based on behavioral symptoms, external symptoms that other people are observing or seeing about you. There's so many there's so many things that can create the same types of symptoms that ADHD creates. So I think it's hard from a differential diagnosis perspective for folks to know what is ADHD, what is trauma, what is a medical issue. And then I think in adults, it's so layered. I think in children, perhaps it's easier because there's multiple people in the mix. There's parents and teachers and everybody who can self-report. And then there's, I think, a more robust medical history and maybe a more excluding of medical challenges. I think as an adult, it's complicated. Although when I'm talking with people about understanding their symptoms, I'm always encouraging them to think about what has this person said? What are you noticing at work? What are you noticing across different environments? So one, I just think If you're going to stick to the DSM where you're excluding everything else and then it's ADHD, then it's really hard because in reality, it takes a lot to do a fully comprehensive assessment where you are really looking at all potential reasons why people can't focus and can't concentrate and excluding everything else so that it is really just ADHD. So I think that's one. I think a lot of times it often is in reality a provisional diagnosis that people are starting with. We think it's ADHD, and so we're going to start treatment for it and then figure things out along the way. I think for most people, for many adults, that's what it ends up being. And then I think for communities of color, there's often a lot of trauma going on. So I differentiate between PTSD, which is going to be single incident trauma, versus more of like your complex PTSD where there's ongoing chronic trauma. Sometimes that happens with folks in relationships. And so I think that is a weakness of the DSM is that it's focused solely on PTSD, doesn't really address subclinical presentations of trauma and how to support them, and the fact that those symptoms can still create challenges and that trauma flashbacks and things of that nature can impact the same parts of the brain that are impacted in ADHD. So the prefrontal cortex can go offline when people are experiencing trauma symptoms. So I think that also makes it hard to diagnose that sometimes people get stuck in this. Is it PTSD? Is it ADHD? Is it both? Which one is driving symptoms? Which one is not? Even if it's not formal PTSD, is there trauma? Is there racial trauma happening? Can a person not concentrate because they're experiencing microaggressions or discrimination at work? Or is it more organic reasons?
Yeah, I do think it's such an important piece and of that sort of overlap of trauma related symptoms and ADHD symptoms. In my experience in my clinical work, most people have more these complex presentations of trauma, and a lot of times developmental trauma, compounded interpersonal trauma over time, but also systemic trauma and structural trauma that they've experienced. I think it will be really interesting. I know a lot of people are advocating in this next iteration of the DSM for them to put racial trauma as a criterion indicator for PTSD. And I think that's going to really broaden our conversation about understanding how trauma shows up, also naming like these intersections of are we supporting people who are experiencing oppression all day in the systems they navigate, and how are we in the mental health fields naming that, treating that is in an individual and broader way. No, I think that's really interesting. And to your point, there's so much overlap in terms of things like concentration and mood and anxiety and depression and PTSD and ADHD. So it really can get confusing, even for licensed mental health professionals, to really decipher these things.
It is confusing. And I think sometimes where it is important is it can impact things like medication, right? Because if we think about the medication recommendations for trauma presentation versus ADHD presentation, it might look different. So I think there's certain things you want to look for to see, are you treating comorbid challenges, in which case you might have to be thinking critically about how to support people with both types. Are you just treating a primarily ADHD case? ADHD often doesn't travel alone, so that makes it complicated. I don't have a single client that's coming to my office that just has ADHD.
Yeah, absolutely. Absolutely. And then also something about the misdiagnosis. This is probably like a whole other conversation. But I grew up in a upper middle class community, largely white Jewish community. And one of the things, there was a lot of highly competitive, a lot of social pressures around achievement. And there was also rampant misuse of stimulant medications, or people who had access to prescribers would essentially feign ADHD presentations to get access to stimulant, to study longer hours. So there has also been this really interesting and strange misuse and maybe weaponizing an ADHD diagnoses within certain subcultures and populations for these same efforts of high achievement and perfectionism. And I think that has also led to an overdiagnosis in some communities that doesn't clearly reflect who does have ADHD.
Absolutely. And I think that really, I worked on a college campus. And so for a year. And so I saw some of that. And so I think that speaks to the fact when people are like, oh, if ADHD medication works, then you have ADHD. No, it works. That's why people are
Perfect.
it works for many people, let's just say that. Yes, I think that does make things very hard. And I think then that impacts things at a level where it makes it harder for people who do have diagnoses sometimes to get access to care because there's so much restrictions on who can access a stimulant and so it's a really tough area because it's something that you have to diagnose from verbal self-report in some ways. And it can be that folks who are not good verbally and who, if you have ADHD, you might have difficulty recalling your history and recalling your symptoms and information like that. So it can hurt those folks, but then also folks who know what to say can easily get diagnosed if they run into the right prescriber. Yeah, I think it's such a complicated challenge
Yeah, absolutely.
for clinicians.
Yeah, absolutely. Can you speak to some of the emotional and clinical impacts of a late ADHD diagnosis for BIPOC client that may already be struggling with executive dysfunction? And again, no pressure, but I know you also mentioned like you had that as a journey. So what do you think are some of the impacts of getting diagnosed later in life?
Yeah, I think it's interesting. I will say one thing I see I don't think it's exclusively a BIPOC thing, but I think it may happen a little bit more is disbelief. So people are like, no, I don't really have ADHD. I feel like I was like, I don't know. I don't really know if this is just a made up. I remember I was like, is this a culture bound disorder? I don't know that I actually have this. And so as I started to read about cross-cultural studies across the world and see that it does show up in various cultures world, that it is a legitimate diagnosis. And so I think disbelief is one that maybe people don't expect of. And how that can manifest is that like people may get diagnoses earlier in life. And then they're like, no, that whether it's a personal disbelief or a familial disbelief, and then there's a discard of the diagnosis. I don't really have ADHD. And then people forget about it for years or decades until something happens. And then they're like, oh, yeah, I was diagnosed back then. And then it's because they got a new diagnosis or because problems escalated. And I think what in the population that I'm serving is that many people can do fine for a long time. But it's as stressors exceed supports that you start to see a tipping point where people get married or they have kids or they move into a managerial position at work. And so now they are responsible for more cognitively and they don't have hacks for that yet. And so then you see a crash. So I think that's one thing. So then you also have some shame and some guilt that happens where people are like, oh no, there's something wrong with me. I'm broken. Should I be telling people about this? Or I don't want to tell people. Or so people go through this process. I just did a podcast about ADHD online dating. And one of the questions was like, should I put it on my profile? So it becomes now there's this thing that I have to disclose and talk about and like stigma and how do I navigate all of this? And I think for some folks, there can be relief. Like we talked about earlier. Okay, so I'm not crazy. I'm not a bad person. I'm not everything that people have said about me. Like someone finally recognizes that I really am trying, but I just can't concentrate. I just can't stay focused. I just can't do this thing. And so that brings people some relief. I think the other part of having a late diagnosis is that sometimes there could be this questioning or revisiting of your whole identity. Who am I? Who was I? Like you're looking at your life through the lens of, oh, so that was the ADHD. Oh, so is that what happened? Or does that explain that? So I think all of those things come with the territory.
Yeah, absolutely. What are your thoughts about this movement in social media spaces about self-diagnosis, whether it be ADHD, autism? What are your thoughts about it?
Yeah, so I will say even clinically, I love the language of executive functioning challenges. And so I always tell people who are in this middle space of you can claim executive function challenges because that's not tied to a diagnosis. It cuts across a lot of symptoms. And I also have had to come to accept that ADHD, the way that people are using it on social media, is often shorthand for executive dysfunction. So what may happen is that people may find other more comprehensive explanations. Like I did another thing on menopause and ADHD and how menopause and perimenopause symptoms can look a lot like ADHD symptoms. So as therapists, we have to accept that when people are using the term ADHD, often they mean they have an executive function disorder. And we don't necessarily know why. We can't necessarily say it's because of neurodevelopmental issues, although you could think about neurodevelopment as happening across the lifespan and not just happening pre-birth and in the early developmental periods. So I think if we expand our understanding, then I think what a person is essentially saying is, I can't focus and I can't concentrate. And when I watch these videos of other people who have ADHD, that describes me perfectly.
Right.
And so that's the lane we can sit in. And again, you can have a conversation about that if you feel comfortable saying, this is what I would need to see to consider ADHD. But I will agree that you do have difficulties focusing or concentrating. And let's see how we can support you around that.
Absolutely.
So that doesn't answer the question fully about self-diagnosis. But I think the thing is, people are going to do it whether we like it or not. And I think it's pros and cons. I think it helps people feel seen and heard and understood, and it helps give language. I think the cons are if it's wrong, it might lead to the incorrect treatment, but it can be wrong and be diagnosed by a clinician.
Right, sure.
So I think that as long as you hold it as provisional and okay, like it could be ADHD, but it also could be whatever else as a clinician we might think it could be. So I think it's hard though when it comes to access to accommodations and resources, who gets to decide who should get access. So
Yeah, absolutely. I know. And I think that's such a good point. Understanding, as you were mentioning, that like sometimes languaging this back to a provider can be really difficult. People don't know what symptoms are. So this, for some people, this can be a provisional. This can actually maybe be a step to getting connected to treatment where otherwise they would not be identifying these things, and we're having a framework to think about them through the lens of executive functioning. But people can get also very tied to something that they saw online and be grasping it really tightly if it feels this maybe feel a part of an identity that they can align with. And even if something might support their recovery efforts from a evidence-based stance in a better way, if they're really like convinced by a TikTok influencer, sometimes that could be hard to compete with as a less cool provider.
Yeah. I'm a psychologist that doesn't do ADHD evaluations. And so I'm sure the folks who have evaluations have probably stronger opinions
Right.
because they have to deal with, I think, people's dismay after you do a full evaluation and we're like, it doesn't look like ADHD, or we think it's more this or that. There's that. But yeah, I think it provides community and support and validation and feeling seen. And I think we really have to step back and help our clients understand that that's really powerful to have. And that's a need that may have been met by this diagnosis. But even if they get a different diagnosis, that need for community and being seen and being reflected back is still really important to find.
Yeah, absolutely. How do you see microaggressions and racial bias complicating the therapeutic process for BIPOC clients who are struggling with executive functioning issues?
Yeah, I think it can make it really hard to access care. So if someone needs care, they may have to make some practical decisions around if this is the only provider that's available to me, that my insurance covers, that I'm able to see, or that has an appointment now, and they're engaging in microaggressions. Do I overlook them and just get what I need from the appointment, or do I address it and advocate for myself? But that might mean leaving this provider and potentially delaying care. So I think it forces people into difficult decisions about care. For us as clinicians, it's important to know that it can turn a client off to therapy. And not just, people don't often say that therapist was terrible. They will often say therapy doesn't work, or therapy isn't helpful, or you can't trust therapists. And so I think it's very tragic when a person, safety to me is the foundation of therapy. When clients feel safe, they open up and they tell you all sorts of kinds of things, really intimate things that they've never talked about with other people or that they don't feel safe to say. So if there's bias that they're perceiving, you're already impacting the dynamic. And it's like they're not going to get the full benefit of therapy if they don't really feel, if I really don't feel like I can tell you that I think I'm being discriminated against at work. If I don't feel like you believe me, if I feel like you're trying to CBT me out of my feelings, it can be really harmful because it can, and the clients won't necessarily tell you. So it can lead to a lot of attrition and you may not know why. But if you have seen a high volume of BIPOC clients and they don't stay very long, I think that's, if you have high attrition rate, like I think it's up to a provider to look at the data. My basis as a researcher. I think you should be looking at things like how long do clients stay? What's the average a new client stays? And if you find that the people who don't stay are BIPOC, then that might mean there's something about your process that isn't feeling comfortable. It can be other things too, because sometimes there can be a layer of class challenges or poverty issues that like may be more relevant depending on where you're located across the country and the communities that you serve. But I think it's still worth exploring. Is bias an issue? Might you be engaging in microaggressions? But I think it's hard because the people who are probably doing that probably aren't going to necessarily do that level of reflection.
But it sounds like two things that you brought up that I think are really good points for self-reflection as clinicians is looking at those attrition rates for clients generally, but also looking, you are having a hard time retaining BIPOC clients, doing a little bit of an inventory of that. What are the questions you're asking? What is your stance? What are the modalities you're using? Do you have a good basis of cultural humility and culturally responsive practices? Like, what are the potential biases? And looking at the media you consume, the people you know, the community you live in, who are the people that you are just like serving, not serving, may have huge gaps in knowledge around that you might need to do some education and work and scaffolding to better support that community if that community is coming to you. Because to your point, like you said, that I think sometimes there's this almost flippancy of, oh, just refer to a specialist. Not everybody has those choices. Accessing mental health providers is still such a challenge, even with some of these expansions that have happened in telehealth spaces. And oftentimes the person is meeting with might be the resource that they have. So it is really a sacred responsibility. We have to try to create safety for everyone that we come in contact with. And then I think the other piece that you are naming is if someone is bringing up a lived experience with microaggression, discrimination, like harassment, prejudice of any kind, and your first instinct is to tell them why it might be something else going on, or there's an alternate explanation, or try to reframe it. Yeah, I think that's something definitely to take a look at of what are you protecting with your own comfort there, or I think just to really catch if there's invalidation in your process when people are bringing that to you, because you might have that one and only chance. If I was on the other end of that, I think I would give someone one chance at that, and once it felt like shut down, I'd be like, all right, I'm wrapping it up. Like now I know I can't bring up this whole host of subjects, which might be really, really pertinent to the person suffering.
Yeah, and I think in private pay, to me, the feedback loop is even faster. Because if you charge a certain rate, people are like, I'm not paying this money to deal with someone who's rude or disrespectful. And so I think, I think it's so hard because I think the reality is when you're in supervision, when you're in training, I think it's easier to probably get that feedback because maybe you're forced into certain environments. But I think once you're out, it could be something like your website doesn't feel welcoming, or the language that you use to talk about something might not make a person feel seen, or so it just is challenging, I think, if you're engaging in these behaviors because you may not be able to get the feedback that you need about like where are you going wrong.
Absolutely. Very true. So, how, in your experience, how does cultural humility or lack thereof affect outcomes for BIPOC neurodivergent clients in therapy?
I think with cultural humility, it can be helpful to know that even if you share a portion of an identity with a person, it does not mean that you know everything there is to know about their specific culture. My background, I have Caribbean influences in my family. My dad's from the Caribbean and my mom was born in the US. And so I don't know what it's like to be West African. I don't know cultural norms. I don't know what it actually is like to grow up in the Caribbean and then immigrate to the US. So I think you have to know enough to know that there's probably a lot that you don't know and that you should be curious, approaching a person from a place of curiosity of what was that like for you, or do you think that impacts your experience or influences your experience? Or I even went back and added a question in my intake to look at culture, to ask people if there are anything that they want to share about the culture that they come from, because I think that opens people up to know that, hey, this is a conversation I'm comfortable having. And I think that part is really important, to bring culture into the therapy room and let clients know that it's okay for them to do that. And if you're from a different culture, to let them know, like, you don't know everything and you would want to know more about how that might be influencing their experience.
Yeah. I love that kind of question of, is there something that you want me to know or understand about your culture so, that I can understand you well? Well, because even if you were working with two people within the same family, that their cultural experience, what's actually like important to them and what's relevant to them in terms of the intersections between their cultural identity and their therapeutic goals can be totally different. Everything you're saying about leading with that curiosity, but also empowering the clients in a way where they don't have to educate us about your example, Western African culture. Like they don't have to come in and give you a dissertation on that. And then being able to be the experts on that and guide the conversation of, this is what I need you to know about my cultural identity. That's going to be important. And then we can always go and do additional work to support them if that is going to be valuable and contextualizing and providing better care. But I think that like opening it up in that way can be really powerful.
Yeah, I think it's creating a space for having the knowledge that culture matters. And it absolutely matters in terms of all of those things we talked about before, trauma and relational trauma and all of that stuff. And being willing to have a conversation or initiate a conversation with clients about it, I think goes a long way.
Yeah. Yeah. How can therapists tease apart maybe executive functioning issues and strategies that are more about self-protection in their different environments or survival? Like for those examples you were talking about before, when maybe what's going on at work is someone is having difficulty concentrating, having difficulty completing tasks, but then there is this element of their bosses making cultural microaggressions. Like how do you start to tease apart what actually might be like adaptive or helpful versus this is like an executive functioning symptom?
Yeah, so I will say that I spend a lot of time in the data gathering and observation phase, and maybe that's the research background. But I like to spend time listening and hearing what challenges people are having and explain them in their own words and just allowing people to come in and share what's happening. The more you see a person, the more you start to accumulate enough information. I listen for cognitions, I listen for thought. And rather than having the client elicit them with me asking them a question, I spend a lot of time taking notes on what are they telling me in their narratives and their stories about what's happening. And then once I have ideas, then I'm asking, is this what you think is happening? Is this the trend that you're seeing? And then allowing them to give me feedback. And so by the time we even get to some, maybe like what are stuck points or what are negative beliefs, I already have a running list of things that they've identified over the course of our sessions. And then I think the other part is trying executive function interventions early and seeing what happens. And so it's in why didn't it work? What went wrong that I think you start to figure out, all right, where are the challenges and where might there be other things that are complicating the picture?
Yeah, absolutely. Are there any treatment modalities or interventions that you find particularly helpful, either with BIPOC folks that are struggling with executive dysfunction or perfectionism? What are like your go-tos there?
Yeah, so I will use an executive function questionnaire, and it's the one from Smart But Scattered. And so it's not an assessment level one, but I think it helps to give people language around what specific executive function challenges that they're having. And then people will then use those labels when they come back into session. They'll say, oh, yeah, I'm having difficulty with planning or with time management or distress tolerance. So I do that. I love brain spotting. And so I don't know that everybody that's listening knows what it is, but it to me it matches with the way that my sessions had started to become over time where I let them be client led. I have them check in, see where they're at, and then for a lot of people it's how do you want to use the time? What do you want to focus on? And some folks really love that unstructured approach to letting them lead and letting them set the agenda and decide what we're going to focus on. Where some folks do want more of a structured approach, and then we go that direction. But I feel like brain slotting really lends itself well because it integrates the mind and the body as ways to get to what's going on. But the client often will still feel in control and they will feel like it having to process at both levels allows them to go deeper and then in CBT. So I like CBT a lot. I know a lot of people criticize it. A lot of neurodivergent folks may have had bad experiences, but I think it's all in who's using the CBT tool and how they use it. So I think it can absolutely be used for minimization, invalidation, things like that. But I think the cognitions are often a really powerful tool in discriminating between what's driving the behavior and what's driving the emotions.
Yeah, absolutely. To your point, like when, especially like again, pulling it out through this narration, like you're helping people understand they're narrating their lives, they're orating the meaning of things and not how that's adding to their suffering. So I'm with you that I think CBT is a really powerful, important, foundational psychotherapeutic approach that I feel like has gotten a bad rap. And I think it's really about the application and people doing it within a lens where I think when it's done clumsily, it can be invalidating. And people who have very real reality-based fears of like stressors, it being implied that their thoughts are maladaptive or not rational. But I think most of the CPT clinicians that I've had the pleasure of working with have a much different approach in like how they utilize some of the like cognitive reframing and other interventions that are really can be so important.
I think that's the key. I think you have to be able to remix it because I think when I was training at the VA for internship and postdoc, to get certified in it, we had to definitely be more rigid. But I think after that period of rigidity, then I was able to play with it a little bit more and just like oftentimes I don't give people paperwork to fill out at home. It might just be the reframing. It might just be showing people a model. So you could argue probably if you're a solid adherent to CBT, then you probably won't like my model because it's heavily adapted and it's heavily modified to really suit what I felt like the folks that were coming into my office wanted. And I would say most of the people did not want a bunch of handouts and a bunch of homework in a very structured way that felt very narrow to them. They liked the narrative approach a lot.
Yeah, absolutely. Absolutely. And then the other thing you were saying about integrating brain spotting, which I think is really important, especially with this population, if we think about particularly for folks who have executive dysfunction that leads more to that hyperactive sort of cluster of symptoms, you could see how verbal psychotherapy could feel very constraining. Come into my office and sit down and sit still and let's talk for 45 minutes to an hour. That so thinking about like somatic based practices particularly people where it's really interesting going through this with my son, and he had the teacher that one year so much of the intervention was about getting him to sit in his seat. And that was like and he really struggled that year. And the next year, the teacher was very free with giving them fidget and giving them bouncing seats. And with very little else but that, not surprisingly, all of his learning and retention and all of these things improved because so much effort was being put into trying to keep his body still when that is not really how his mind works. And there was so much masking. The energy that was being drained and poured into doing that was actually like, we think about what are the higher order goals of being in school. Holistically, I hope like him learning and being more knowledgeable and liking to learn and thinking critically are part of it. And was that serving him to like really practice keeping his body still, like from an obedience standpoint, maybe, but certainly not from a learning perspective. So I think in our own psychotherapeutic practices, thinking about so much of our suffering is felt in our body, so much of our discomfort is felt in our body, and so much of our psychotherapy offerings are verbal and cognitive and things like that. So I do really love that you are pulling in that brain spotting as practice. Yeah.
The story you're telling to me explained why I like brain spotting so much, because a lot of neurodivergent folks have trauma around like, I have to show up like this to be seen as acceptable or to be okay. And it's like in therapy, I have to talk and say all these things. So I incorporate some stretches of silence into my brain spotting. And a lot of people like that because people can process at a deeper level. Or sometimes people want to talk the whole time. And I'll have folks who apologize in the beginning, like, I'm sorry, I'm jumping around so much. And even before I did brain spotting, I was like, that's fine. Let your brain go wherever it wants to go. And so people appreciate that freedom to not be contained, to jump topics and to bounce between different concepts and ideas. And that is okay. That is actually a beautiful thing. And whatever it is, that I think the flexibility can help people be able to process at their own level. I think a lot of folks appreciate a somatic approach because it may resonate with how they're experiencing the challenges that they're having and how they see wellness in terms of being more integrative. And yeah, I think I'm finishing up my certification and it's been a really exciting process.
Amazing. Yeah, and it's just so interesting too, you're saying about that feeling of like, having to not take up space and not being a way of masking. I think in my anecdotal experience of, I work largely with healthcare professionals, a lot of residents, doctors, nurses, and my BIPOC clients, some of the things I experience them running into more is these issues of professionalism that feel like much more culturally bound. And I was thinking about somebody that came to mind who got feedback about, and which is, it's so bizarre to me because I'm from New York. Everybody talks with their hands. Are you even talking if your hands are not like all up in the mix? It's funny because I had to change my settings, but I had that Zoom thing where I was like constantly accidentally raising my hand in the Zoom session because my hands are always going. But this person got feedback that about their use of their hands when talking, and it was almost framed as an issue of professionalism. To me, it felt very racially loaded. And I think thinking about some of the things that happen with executive functioning difficulties for people who are high achievers, have perfectionist setting, and some of those sort of cultural frameworks of professionalisms and how the tension between them, I imagine that being like a big boiling point that could come up in this work.
Yeah. And that's where I feel like the cultural masking is, that after receiving those messages for so long, people have just naturally chopped off those parts of themselves.
Yeah.
But then it becomes they're masking so much of who they are so much of the time. And then if you've got a mask in the therapy room too, it's just really tough. And like you said, things that are considered to be normal in some cultures will get mischaracterized, and it can be really harmful and such a just tough experience to have as a BIPOC professional.
Yeah. So how do we support clients in looking at their self-concept to include executive dysfunction or neurodivergent in a way that might feel more empowering or support their resilience?
Yeah, so I think everybody should get trained and get experience in how to support adults with neurodivergence. I don't think it should be siloed. I think everybody should have training in how to work with autistic adults. Everyone should have training in how to work with ADHD adults. And everyone should have training in how to have cultural humility. And it shouldn't stop with the diversity training in your graduate program. It should keep going. And that training shouldn't just be formal, but it should be consultation with colleagues, right? It should be just when you have time learning about topics of interest to you, just like everyone should be trained in how to support LGBTQ community. So I think it is about really understanding that as a clinician, you're going to see people of various backgrounds and that you should be prepared to know how to get more support when you need it, when to consult, when to check in with clients about, is this helping? How is this going for you? Are we meeting the treatment goals? So I would say that's one other thing I would say is collaborative goal setting. I think, yes, we can have ideas for how we think the client should be progressing and what goals they want to have, but I think really checking in with them. What are your goals for therapy? What are your goals for treatment? This is what I think you should work on. Do you agree? Do you disagree? And then I think also I like to give a lot of qualifying statements. Sometimes I'll say, I don't know if you're going to agree with me about this, but if you don't, you can let me know. And so I think I make space for myself to be wrong.
Yeah.
I try to create that culture of I might not be understanding you properly. I might be getting it wrong. Or like I'm known for saying I just talked a lot because of my own ADHD, right? And so I'll say, I just talked a lot. So I'm going to step back and let you chime in. What are you thinking? Or what was your response to that? So I think always giving the opportunity for someone to share a different opinion, share a different perspective, for someone to say, no, you got it wrong. You like, that's not actually what happened, or that's not how I saw it. And then you say, oh, okay, glad you spoke up. Thank you for sharing. So I think creating that culture of, I'm not going to get everything right. And that way, to me, you're dismantling the power dynamic a little bit, because there is obviously an inherent power dynamic in therapy. But I think you want to try to find ways to give power back to the clients or check in to make sure that they are feeling like they got what they need out of this session or out of the whole therapy experience.
Yeah. And I like that you're doing it very explicitly, right? Because I think that invitational language of, like, you can absolutely tell me when I've gotten it wrong. So I think that piece of just like really giving people permission that they can like re-navigate it, and they don't have to protect you and your feelings. They don't have to protect themselves by pretending it's fine when it's not fine. And then it gives them other options besides what you were speaking to before, where they'll communicate by not coming back. They'll communicate when you keep that open dialogue, that you care about them feeling safe and heard and understood. It's a way to really keep that engagement.
Yeah, and I will even say, like in the beginning, sometimes that you'll know if you like me in the first couple sessions. So I'll set the frame for the fact that therapy, this might not be a good experience. And I'm like, if it's not, let me know. And I'm happy to find you another therapist. So to me, I try to head off the attrition by saying, you'll know quickly if it's a fit or if it's not a fit. If it's not a fit, let me know. Let me know so that we can try to troubleshoot it, or it may not be a fit. Sometimes it's just something simple. Yeah, I don't like coming weekly, or I don't like coming in the daytime. I need to come at 6 o'clock. And it's okay. Let's find you somebody who's willing to see you at 6 o'clock so that you don't feel this tension every week. So yeah, I think it's really knowing your community, knowing what the anxieties are, and then I think also examining your attrition carefully. Because sometimes we know we're like, I bungled that. I see like why they might be upset or might be frustrated. So I think it's important in communities where there's a lot of relational trauma. That might be a lot of the work that we're being called to do, which is we're creating a relationship where we want to make it safe for people to voice dissent or voice negative feedback in a healthy way. It may be a way that they have not had experience with previously, especially with folks who have power over them.
Yeah, absolutely. Absolutely. I think that's really helpful, doing that inventory. And I think as clinicians, we're working really hard. We're like putting our effort forward. And sometimes when it doesn't work out, we can be very self-critical. And maybe sometimes it's also easy to be like, oh, well, the person ready, like they had other therapy interfering things that are going on. But I do think this is important work to really hold this and in a self-compassionate way, right? To be able to say, let me evaluate what's going on, because I do think at some point in our career, this is going to be inevitable for all of us. We do have to hold the humility that we are going to have to grow and work really hard to serve diverse community members. And what does it require of you? And sometimes it's only in something not working do we get that information. And so not letting that moment pass without getting that growth and learning opportunity, even if there's not an opportunity for repair, if there is, fantastic. And if there's not, there's still growth to be had from those experiences.
Yeah, I think the repair is so important, just like in medical, where surgeries go wrong or things go wrong. It's not the fact that something went wrong. A lot of times, like what determines if people sue is how well you handled it, the approach that you took. And so I think for us, it's really how we handle the ruptures and how we handle the repairs that really can make a difference, because ruptures are going to happen. We're human. We have our on days and we have our days where we're not so hot sometimes. And so I think it's just, or sometimes clients can poke the bear a little bit. So I think it's just understanding that ruptures sometimes happen and how we repair rupture can really make the difference.
Absolutely. Especially if part of what you're working through is maybe they're dealing with a bunch of people not taking responsibility for being subjected to bias. So if you are at least, that's part of what's harmed them, that's something that you have unintentionally participated in, at least that piece, even if the relationship therapeutically doesn't continue, being able to say, I can take responsibility for hurting you or harming you in this moment. I do think that can be really valuable. Thank you so much. I could talk to you all day, so respect your time. But can you tell our listeners where to find you, where to find more about this important work that you're doing, how to connect with you?
Yeah, so probably the easiest way to find me is the website www.drspllc.com. Doctor, my initials SP LLC. I'm there, and there are ways that you can reach out if you want to schedule like one-on-one consultation, if you want to learn more about adjuncts that I do for folks who just want to, therapists who want to send clients for a few sessions or for a brain spotting intensive to get some support and then take them back. And, or if you have anyone that you want to refer as a client, if you want me to come speak to your organization, any of those things you can do through the website. If you want to follow me in the content that I'm releasing, which is a lot of times just videos or random things, random updates that are going on, I'm on Instagram at Dr. Shauna P, DRSHAUNAP. I'm on LinkedIn with my name, and I think those are the major places. So website, LinkedIn, Instagram. Yeah.
I'm gonna link all that so it's easy for people to find and connect.
Great.
Awesome.
This was
Thank
a
you.
fun combo.
Yeah, absolutely. Thank you so much.
Thank you for joining our community on the Affirming Minds podcast. If you loved this episode as much as we did, please follow us wherever you listen to your podcasts and share it on your socials. If you want more information about how this podcast can add to your continuing education credits, visit affirmmentalhealth.com. And remember, let's affirm, heal, and grow together.